My talk this evening, as Jason has said, is on military medical revolution, how we and the Defense Medical Services transformed in conflict in those very, very busy years, 1990 to 2015. A couple of definitions at the beginning, because military revolution is also known as revolution in military affairs. And that debate as to whether a revolution had occurred started really after the first Gulf War, 1990-91, in particular when Saddam Hussein's forces in Kuwait were very rapidly overwhelmed within days. In fact, the whole war lasted, the ground war lasted about 100 hours, with complete defeat of the Iraqi forces, overwhelming victory by the Allies. There was a revolution in technology and more besides. I've got a couple of names here, which I'll introduce in a minute, but then beyond military revolution, we're talking here military medical revolution. And amongst that, our current Surgeon General, Timothy Hodgetts, has been really influential in that. Please read that definition by a Pentagon analyst in 1994. He worked with Andrew Marshall at the Office of Net Assessment. It's a detailed but very important definition. It's new technologies into military systems, combining with concepts and organizational adaptations. Colin Gray's definition is easier to remember. It's a radical change in the character and conduct of war. A radical change in the character and conduct of war. If you think about what's happening right now in Ukraine, with new technologies being used in that war, there's drone warfare, for instance, just one aspect, there's hypersonic missiles. That's a change in the character and conduct of war. So wait out to see what's happening nowadays as well. Elliot Cohen, Professor Cohen, formulated 3 tests by which you can assess, is a revolution really occurring, or is it just a process of change, incremental change? What actually is revolution? Well, these definitions, these tests, show what transformation is really about. Do the forces look fundamentally different? The processes of battle are very different. And crucially, are the outcomes significantly different? Now, behind that transformation lies a paradigm, a worldview underlying the theories and methodology. A classic example is from Ptolemy. For centuries, people thought that the sun revolved around the earth. That was the old paradigm, the old worldview. It was Copernicus who asserted, no, it's the other way around. The earth rotates around the sun. Think about that change in a worldview. The equivalent happened in military medicine. The old paradigm, ABC, that's airway, breathing, circulation, how you resuscitate a patient, was developed to deal with blunt trauma, blunt civilian trauma, road traffic accidents, for instance. This was the foundation of the advanced trauma life support system introduced by the American College of Surgeons. And that became the gold standard. But this was developed in peacetime, dealing with blunt trauma. It was not as relevant for military medicine, for the battlefield. And the major paradigm shift occurred in 2005, with the impetus behind that of the Somali campaign of '93, And people will remember Black Hawk Down and a person in particular bleeding to death from a groin wound. And then the second impetus was the second Gulf War on Iraq in 2003. The recognition that the main killer on the battlefield is catastrophic hemorrhage. Now, if you know your history, that's not new. The First World War, the Second World War, surgeons, medics recognized that people died of hemorrhage. But the old paradigm which had developed of blunt trauma, which therefore was how all of us grew up learning, meant we didn't give due assessment to controlling hemorrhage as the first point rather than the airway. That change is ABC 2, C for catastrophic hemorrhage, deal with that first, and then go on to airway briefing circulation. That underlies everything we've been doing since 2003 in particular. The aim, therefore, in combat trauma, in military medicine, is to try and prevent the potentially preventable deaths, because it was recognized that a quarter of people who die on the battlefield, those deaths are potentially preventable. And it's mainly from hemorrhage, whether it's internal hemorrhage, 2/3 of those, junctional, or on the extremities. And these are the challenges to deal with. So that is the aim. So I mentioned Cohen's tests, 3 tests for evolution, how we transform in conflict. Well, Timothy Hodgetts, in his PhD thesis of 2011, formulated a subtle change. Do the military medical forces look fundamentally different? Are our processes different? And are our clinical outcomes different? And they sure are. But to get what have been the drivers for change? The main driver for change was sustained heavy conflict, sustained, going on not just a short period of 2 months, 3 months, with just a few people deploy, but a sustained conflict that we've been involved in particular since 2001 and the 9/11 bombings of the Twin Towers. Sorry, the impetus of Iraq and Afghanistan, whereby all the defense medical services deployed repeatedly, so that everyone knew they were deploying, or they've just come back from deployment, or they're training people for deployment. All our field hospitals, the regular ones, and our reserve field hospitals deployed at least twice, sometimes 3 times during those years, so that every single member of the Defense Medical Services had a personal incentive to care for casualties and to improve their care. It encapsulates, therefore, a military medical revolution combines a change in doctrine and your concepts. There's technology involved, plus the organization has to change, and change when you're on operations. Easy to remember, it's a radical change in the character or practice of military medicine. That's what we have observed. So let's go through these in turn for examples. And in the meantime, I should acknowledge the background portrait there is by Stuart Brown, and it's called In Safe Hands. And that's what this is all about. So, doctrines and concepts. We've formulated these various elements. Care on the battlefield, I'll come to that. The question mark, tourniquets, yes, that's technology, but it's a concept of, do you use them? Yes. Do you not use them? Or how do you use them? En route care, I'll expand on this, and then it's resuscitation of the casualty. and then going on to the evacuation of casualties. Let's go over these in turn. The battlefield advanced trauma life support motto, introduced by Ian Hayward to the UK from the States. The motto is deliver to the surgeon a live casualty. It's pointless having the best surgeon in the world and the best surgical teams if the casualty doesn't survive en route. So, care under fire, what do you do? And the emphasis all along is catastrophic hemorrhage. Get that bleeding stopped first, but don't get shot in the meantime. Once you're under cover, that's now tactical field care. You can do a little bit more. And then the enhanced field care is when you've got the medics on the ground giving you extra techniques. So a lot depends on buddy first aid, training every soldier in the British forces to care for their buddies. So the concept is tourniquets. Yes, no, or how. And this is a photograph from the Museum of Military Medicine, a diorama there. And you'll notice on the left, around the thigh, a medic is placing a combat application tourniquet, or CAT for short. He's under shelter. Just behind him is what's known as a HESCO bastion. So this patient's undergoing tactical field care. They're under a minor degree of cover. So in 1990, at the time of the first Gulf War, it was the doctrine, the teaching was, do not use tourniquets, do not use them, except as a last resort. And all we had when I deployed to the Gulf was ineffective World War II equipment. So it was not surprising that tourniquets were said only use them as a last resort, because the technology available to us was not that good. And certainly at the time of 9/11, very few soldiers had tourniquets of any sort, and there were no hemostatic dressings available. But then come Optelic 1, 2003, and from 2006 in particular, after development technology there, every soldier, not just a medic, but every soldier was issued with tourniquets, the combat application tourniquet, as well as hemostatic dressings, also known as the Israeli dressings, based on chitosan and other materials. Think about that change in those few years. So the question is, yes, apply tourniquets, you're trained to use them, and how to use them. The medical emergency response team is the concept derived from Afghanistan in 2006, when the 16 Air Assault Brigade deployed into action, was to take effectively a consultant-led team forward in a Chinook to the scene of wounding, putting your experience, your most senior personnel actually at risk to retrieve that wounded casualty. Now, to be fair, we had air superiority, but nonetheless, that Chinook was extremely vulnerable to handheld anti-aircraft missiles. So regardless of air superiority, they were always at risk of being shot down. But here you had consultant-led senior expertise for that one patient, two patients, three patients on that Chinook, or more as required. And it's CABC, catastrophic hemorrhage, deal with it first. Now this is a painting at Camp Bastion Hospital. That Chinook has landed. The fire brigade team have gone in, retrieved the casualty, straight into the ambulance, and the ambulance is on the way with that MERT team, that medical emergency response team, on board that ambulance on the way to the emergency department. Here you can see Nightingale helicopter landing site in the background there, and they're coming in and moving straight into the emergency department, giving a handover to the team awaiting them in the emergency room. And it's not just one or two people. It's a huge team of people, anaesthetist at the front, team leader, overall control at the foot of the bed, hands off, and then everyone's got their role. And it's damage control resuscitation. This is a layout map from the Hospex tabletop exercise showing Camp Bastion Hospital, Role 3, in the year 2007-2008, when at that stage it had just had the first CT scanner introduced into theatre. And you'll see rooms 1, 2, and 3 are emergency base 1, 2, and 3. You've seen the photo at the back of the emergency department entrance, and the casualties would normally go to 1, 2, or 3, except the theatre was on the right. So if the patient required urgent surgical resuscitation, they would turn right into theatre, and the whole emergency team would deploy into the theatre. So that surgery became fully part of resuscitation. Hence the term right turn resuscitation. That term is very much in use now worldwide, but it's taking the right decision at the right time for the right patient, making the right decision. It's part of surgery, is part of resuscitation. That patient now moved to intensive care, and then from intensive care is being evacuated. And the critical care air support team, and the equivalent in the States, is effectively a flying ITU, with a whole ITU team looking after the casualties, the most critical casualties en route through to home base, Role 4. So that's doctrines and concepts. The next one is technology, technological revolution. There have been many advances in hemorrhage control, and I'm delighted to see Heidi Doughty here, who was the topmost consultant in hematology for the Defense Medical Services for most of these years. There were advances in intraosseous infusions. So the patient, for instance, in that helicopter or on a moving ambulance could be infused as required and with blood as well. Transfusion advances. Heidi here was involved with the introduction of platelet apheresis. So taking fresh blood and getting platelets to those patients to improve the clotting. Damage control radiology, I'll come on to that. There have been huge advances in personal protective equipment, not just in the helmets, but in the body armor that people wear. And limbs, Role 4, tremendous advances in prosthetics over the years, such that you've got Olympic class sprinters here. And with all trauma comes pain. So there have been developments in analgesia, particular lollipop, fentanyl, and so on. So just to go over a couple of these, the first CT scanner was introduced to Camp Bastion in 2007. That was the first time we've ever deployed a CT scanner in the field on operations. The first radiologist deployed in 2009. In that interim, we were using teleradiology to transmit the images back to a consultant on call who would advise as to what was found, but it was far more effective having a radiologist actually deploy and actually in the emergency department as part of the trauma team, giving instant advice and helping out, for instance, with ultrasonography. Organizational and operational revolution. This is a huge, huge part of that. It doesn't matter how good your technology is if you aren't trained to use it and if you don't assess the results of what you're doing. So here, the organization around that developed over the years through to people like Pete Mahoney, many other people, Timothy Hodges, again, I mentioned, capturing data. The States developed the Joint Theatre Trauma System. The UK equivalent was the registry, so you had a person, a trauma nurse coordinator, alongside the emergency team, collecting all the information and then relaying it back to the UK, reviewed very quickly through the joint theatre clinical case conferences. So you get very rapid feedback to the surgeons and the emergency department teams. Because normally, once a patient's been evacuated back to the UK in the past, you would have no idea as to whether you'd done right or wrong by them and could not learn from any mistakes that might have happened. But here we were getting feedback on a regular basis. I'll mention the other two in a minute. Crucially, remember that last test, are clinical outcomes different? And that is reflected by the sheer number of unexpected survivors over this whole period of time. Let's come on to these. So the first, what is a deployed medical director? Until about 2009, the senior doctor on that particular deployment would effectively be clinical director. He'd have a command role, but also a clinical role at the same time. And also, if it was, say, a consultant surgeon who happened to be the most senior, or a consultant emergency medicine doctor or physician, they would get sucked into the clinical management individually of the patient, that they personally had hands-on management, and they could not have the bigger picture of what was happening outside that room with other patients. So it became very obvious that you needed to have a standalone doctor, the deployed medical director, who would have no hands-on role, so he could, as it were, assess, basically command and control. And he was very much alongside the commanding officer of the hospital, and very much alongside the senior nursing officer of the hospital. So here you've got a triumvirate. So the deployed medical director, and here he would lead combined ward rounds. Here's an interpreter, and they're talking, discussing the management of a particular patient in Afghanistan. Multinational collaboration. Here in the audience today, Jim Zarnik spent several years here with us in England. Jim, I'm delighted you are here, and it's I can say a huge thanks we owe to the United States, because from the year 2009, we had between 40 and 100 United States personnel deploying to Camp Bastion on year-long deployments. We also had Estonians. An Estonian team was embedded with us for many years, and we had a Danish squadron for several months as well. This particular background in the intensive care unit reflects when the Danes were there alongside the Americans and the British. At times there was a lone Maltese surgeon, I must admit that, but I wasn't waving that particular flag under these circumstances. But nonetheless, I think I might just wave it now. Purely because in a week's time is the anniversary of the award, the 80th anniversary of the award of the George Cross to Malta. But that was another campaign. Moving on. But it's multinational collaboration. That was the States helping there as well. So crucially, I mentioned, are the clinical outcomes different? And yes, they have been different over the prolonged period of time. I'll explain this graph. Look at the arrow indicates 50% probability of survival. 50% probability of survival over time. The chart on the left here, this one here, represents the year 2003, 2004, 2005, 6, 7, 8, 9, 10, 11, 12. Think here, you've got a new injury severity score of injury. Say you had 35. You had less than 50% chance of survival in 2003 if you came into hospital. But if you came into hospital with that level of 35%, by the time 2012 occurs, you've got a really high chance of survival. Even more so with the more critically wounded patients. In the past, 75 new injury severity score was universally fatal. Universally fatal. You had practically a 0 chance of survival. As the years went on, there was a chance of up to 20% chance of survival. That comes with experience, competence, the dedication of so many people introducing different organization, different technology, different concepts and doctrine and training. Now, this happens in broad terms throughout every prolonged conflict. At the beginning of the First World War, the casualty rates were much heavier compared to the end. In the Second World War, survival rates were poor at the beginning, better at the end. But here's the unexpected survivors, which is a real hallmark of military medical revolution. I would like to quote from one particular patient. From Private Darren Elagi, who was an unexpected survivor. I'm just checking here. Now I'll come back to that. Here he is. Private Darren Elagi sustained a bilateral through-thigh amputation when he stood upon an IED, improvised explosive device. They took me to Camp Bastion, the field hospital, which took about 20 minutes. Once I reached it, they took me directly into the operating theatre. And the last thing I remember was a nurse talking to me. She said to me, "Derek, be strong. You're going to be okay." He had undergone right turn resuscitation, and he was one of those unexpected survivors. And there have been something like 400 unexpected survivors from Iraq and Afghanistan over these years, still alive today. So, the 3 tests for revolution: transformation in conflict. Do the military medical forces look fundamentally different? Yes. Are the processes of battle different? Yes. And are clinical outcomes different? Yes. So if we've sustained, as has been proven, a military medical revolution between 1990 and 2015, and here we are now in 2022, we are in a time of peace as far as the UK Defence Medical Services are concerned. They are not deployed currently on operations dealing with a heavy trauma load. So the challenge is sustaining that revolution. And the question is how? For the next conflict, which may be just over the horizon. Crucially, those military innovations go both ways. The civilian adoption of military innovation and the military adopting civil innovation as well. It's a synergistic effort. Crucially, we have to promote military medical research. As A former commandant of the Royal Army Medical College Millbank said, Sir David Bruce, it is in peace that we prepare for war. Transforming after conflict. After conflict, we have to sustain the training through doctrine, embedded concepts in doctrine, so that it becomes taught to the first medic in, so that they're ready for when they go to war. I was a consultant surgeon, but I'm now been retired for 4 years. That happens, that's part and parcel of life. So crucially, we need to prevent the loss of corporate knowledge. Now, Role 4 care is now embedded in the NHS since our military hospitals, the standalone military hospitals in peacetime in the UK, closed down completely in the 1990s. There was a period of time in the mid-1990s when the Defence Medical Services were under threat of complete implosion, and was thought that they would never again be able to cope with a conflict. Look how things have changed through are being embedded in leading world-class trauma hospitals, like in Birmingham, the Royal London Hospital, Oxford, and others around the country. So that, think, we've got staff rotating through a hospital like Birmingham with 100+ ITU beds. So you've got to maintain that level of clinical involvement. So yes, one might miss our old military hospitals. Don't forget the lessons learned through there, but look to the future, adapt in the present, because our patients, for the benefit of our patients. And how do we do all that? Through powerhouses of revolution. What are they? There's the preparations for the war. Battlefield Advanced Trauma Life Support has adapted over the years. MIMS is major incident medical management and support courses. See how best to deal with major incidents on a daily basis. The MOST was the previous name, Military Operational Surgical Training at the Royal College of Surgeons of England, and HOSPEX, Simulation Training. I think that the only one of all these that currently does not exist is Bastion Hospital. But the lessons from Bastion Hospital are still with us. Those lessons are still with us. Role 4, I've mentioned Birmingham and the Royal Centre for Defence Medicine alongside that. So worthy successors of the Royal Army Medical College at Millbank. They have the same motto, ever to excel for the care of our patients. After wounding comes rehabilitation. And Headley Court was a world standard rehabilitation centre, which evolved over the years under the impetus of many casualties, single amputees, double amputees, the triple amputees coming in, and nowadays Stamford Hall. Trauma is not all physical. There's a huge impact on mental health. And the King's College, London, the King's Centre for Mental Health Research is really active. An excellent website for those of you who are interested. And research, we're embodied in Imperial College London, one of the top world organisations with a Centre for Blast Injury Studies, named after the Royal British Legion, Blast Injury Studies, with embedded military personnel. These are the current powerhouses evolved and carrying on. A couple of examples, I mentioned the HOSPEX. This is the HOSPEX trainer up in Strensall. Huge warehouse, huge warehouse. Most of us in this audience would have been through there, a few not. And you simulate the exact layout. You've seen that map I showed you earlier, that HOSPEX tabletop map of Bastion Hospital in 2009. And this photograph is exactly that. And you're looking here at emergency room 1, Bay 1 and Bay 2, Bay 1 and Bay 2. And there, just a bit further on, is the entrance into the operating theatre. So a patient coming from the right, in this case, if necessary, would go into Bay 1, 2, 3, or right turn recess into that operating theatre. So the whole hospital staff would come here to practice at least twice in the build-up to them deploying. So that they'd embed together as a teams, they'd know their concept, their doctrines, their training, everyone learning from one another and passing on that knowledge to the next team and the next team. And the beauty of this system here is that configuration can alter depending on where you're deploying to. So the same thing happened for Ebola in Sierra Leone. The same thing has happened elsewhere. And crucially, it's also happened for NHS training. Now, as you may imagine, this is a huge, huge setup. Lots of organization involved in getting that training. So there are simpler ways. It's a building block approach to training. I'll mention just one of them, which I was personally involved in developing, the Hospice Tabletop Trainer. Here, for instance, is a map of that same Bastion Hospital, bays 1, 2, and 3. And every card there, for instance, represents a member of staff. So as required, a team around that table would practice their concept, their doctrines, and decision-making processes as a build-up to going to that hospice trainer. And every one of our field hospitals now has a set of this. There's much more to it than just that. This is just showing you the map and the layout. There's much more to it than that, but it's a simple method of training. And you can expand that and just have even a large room. Think of a dining hall with tables laid out to represent individual departments. So the imagination is the challenge here, developing simple methods, low-tech technology, low-tech simulation training. So where were we in 1990? That was my very first deployment to an actual conflict zone, 1990. And there was no tactical context for care. We didn't think of care under fire or tactical field care or enhanced field care. The trauma training was based on ATLS, ABC. That wasn't a combat-related trauma, of course. And our medics were taught not to use tourniquets. We had no hemostatic agents, no dressings impregnated with chitosan and such like. There were no junction, no tourniquets at the level of the groin or the axilla to stop that level of bleeding. And I well remember we used to pour in saline to replace blood loss. And we'd have 2 large bore IVs on all casualties. We only had intramuscular morphine out in the field, and we had no concept of preventing trauma-related coagulopathy. And we were taught intubate the patients. It's unrealistic. You need trained anesthetists for this. So by the end of this time, over this 25 years, a single generation, we had phased care, all in doctrine. What do you do at different levels? The CABC concept, aggressive use of tourniquets initially, that's not just on the limbs, but junctional ones as well, and pelvic binders. Combat gauze is now our hemostatic agent. Relief of chest trauma, surgical airways, instead of the emphasis of endotracheal intubation. And now it's blood, the massive transfusion protocols, full blood, single unit of blood, platelets, fresh frozen plasma. And the emphasis on intraosseous access is required. Analgesia has come on in leaps and bounds. And there have been more developments since then, including ROTEM. This was the state 7 years ago. We're even more advanced now. We have been sustaining revolution since then in further developments. I'm delighted to see that. A recommended reading online online Timothy Hodgett's PhD thesis. You can download it, and that's an excellent. I think we owe a lot to our current Surgeon General. I've given a talk here today on military medical revolution. That was the basis of my MA thesis on history of warfare. That is in a book, in a hardback, current and only available from the Museum of Military Medicine, raising funds for the museum. One can also order it online in paperback, but the only hardbacks are available from the museum. Now, isn't that a beautiful scene? At peace. This peace is not bestowed, it is achieved through sacrifice. Those are the words on a war memorial in Malta to HMS Olympus, a submarine of the 10th Submarine Flotilla, which was lost with all hands on board when it struck a mine outside Grand Harbour, with a loss of 80 personnel. Those men sacrificed their lives, as many other men and women have sacrificed their lives to bring peace and comfort to the wounded. There's another saying here, not on this slide. If you want peace, prepare for war. If you want peace, prepare for war. Because it's only then that you can either prevent war or deal with the consequences of war and the victims of war as effectively as possible when, not if, when war breaks out again. This is the motto, and was the motto of the Royal Army Medical College Millbank. I'm delighted to see that that is the same motto that's carried on, and it embodies what we are all about, ever to excel for the benefit of our patients. Thank you very much for listening to me. Jason, thank you very much indeed for inviting me here today to speak to everyone here. Over to you, and thank you all for your part in military medical revolution.